Good evening, everyone. Come on in. I cannot wait to get started with you this evening. Good evening to Encouragement Along Your Way Journey. And this is Pastor Cynthia, and I'm so looking forward to this broadcast this evening. When you come in, please let me know that you're here, and we so look forward to having you. Come on in to Encouragement Along the Way. Good evening. Good to have you. Good to have you. As you're coming in, please put in the chat that you're here so that I know that you're online. We look forward to getting started with our guest this evening. Come on in. Yes. Good evening. Welcome. Welcome. Welcome everyone as you're coming in. We're so happy to have you. Just please put your name or say hello and let us know that you're here. Welcome. Welcome, everyone. This is Pastor Cynthia, and I'm the founder of Encouragement Along Your Journey, and we are so excited to have you here. Come on in. Welcome, everyone, as you're coming in. Welcome, welcome. Yes, good evening. So excited to have you here. We're going to get ready to pray and open up in a couple of minutes. So come on in and let us know you're here. Yes, thank you for letting us know that you're here. Welcome, everyone. Welcome. Okay, let's go ahead and open up. Father, we just thank you and we praise you. We honor your great name. We thank you so much for this day. And we thank you so much for everything that you continue to do with us and through us. We thank you for this time of just being able to celebrate and to hear, to be aware and to hear, Lord, what you have for us and what you want to give us in regards to not only just cancer, but general medicine, Father, and being able to learn how to advocate and how to be there for ourselves as well as for others, God. We thank you right now for each person who will be attending online live and also those who will see the broadcast later on, Father. I pray that it will be a blessing, Father. For this broadcast. And we thank you for our special guests. And we just love you right now for all that you do. We give you praise and honor, Jesus. We give you praise and honor in Jesus' name. Amen. Amen. So welcome everyone. Welcome, welcome. Today, encouragement along the way. You guys know this is a safe space for you to come in, just for you to let go of everything that you might be dealing with or feeling and just come into a space for you to be encouraged and inspired, for you to be motivated to keep moving on, to hang in there. We all need some coaches and we all need some inspiration every once in a while. And we're here every Monday evening, second Monday and fourth Monday of the month. And we're here to give some inspiring words for you. Now, this month is October, and it's normally the month that we celebrate breast cancer awareness and education. We celebrate and we also remember. And this month on Encouragement Along the Way, that's what we're going to be doing. We're going to be celebrating, we're going to be honoring, we're going to be making sure that you have information that you need around this topic. And we have a guest here who will be given that information, and we're going to bring him on in a couple of minutes. But I also just want you to know that we're going to be celebrating throughout the whole month, and I'll talk more about that later on this evening when I make the announcements. So I'm going to go ahead without further ado. I'm going to bring on our guest, and I'm so excited to have him. Let me bring him in. Dr. Levi Downs, it's so good to see you, sir.
Great to see you, Cynthia. Thanks for having me.
Thank, thank you. So, Dr. Downs, and I know that I'm being very formal here, but I'm going to break protocol a little bit because I know him. We grew up together. He's my cousin, but pretty much he's my brother. We all grew up together. There were six of us. And one thing about Dr. Downs is that he always knew what he wanted to be. And that was something that I was very, I wouldn't say envious, but I was just kind of, wow, he knows he wants to be a doctor. As a little boy, he just always knew he wanted to be a doctor. And he really accomplished that and more. He is not only just a doctor, and but he has so much that he has accomplished, and he might talk about it and he might not because he's very humble, but I just need him to know that I'm very proud of him and of all that he has accomplished, and he has helped so many people. He's on lots of different boards. He has received different awards. He's done research on cancer, and he really has done some great things for our society in this world. And I'm so proud to have him here with us. So, Dr. Downs, can you just briefly tell us just a little bit about your medical journey?
Okay. Thank you, Pastor Cynthia. Thanks again for the invitation. I'm really happy to be here. Um, Cynthia knows that one of my favorite things to do with regards to using my knowledge around healthcare is to help other people understand what's going on, particularly with this very frightening diagnosis of cancer. So that's what I'm going to do today. But to start off at the beginning, sort of what's my journey to being the physician that I am. So as Pastor Cynthia mentioned, I am a gynecologic oncologist, which means that I take care of women who have cancer in the reproductive tract. So specifically, there are 5 cancers that I take care of: ovarian cancer, cervical cancer, uterine cancer, and then very rare, but also diseases that I treat are vaginal cancer and vulvar cancer. So to be a gynecologic oncologist, the training is after high school, you go to college and medical school, which is 4 years. And then gynecologic oncology is a subspecialty of obstetrics and gynecology. So I did a residency in OBGYN for 4 years. And then after doing that general training, I did a 4-year fellowship where I specifically learned the details around taking care of women with cancer, which includes delivering surgery for women, as well as doing chemotherapy and then taking care of patients throughout their surveillance, and for many women, taking care of them for the rest of their lives. So one of the things that's a little bit different about my specialty as a gynecologic oncologist is that we're trained to not just do surgery for cancer, but we also give patients chemotherapy. So something a little bit different than a woman who might have breast cancer, who sees a doctor for her diagnosis, which is usually her family medicine doctor or primary care doctor, and then gets sent to a surgeon who will do surgery to remove the cancer. And then she'll see a radiation doctor and a chemotherapy or a medical oncologist. In the cancers that I take care of in this field, it's one of the few, in fact, we're the only field where we're trained to do the surgery, we do the chemotherapy, and then we do the surveillance for patients after they're diagnosed. We partner closely with radiation doctors, but we also know the delivery of radiation and that management as well. So for me, it's a very attractive field because I get to do such a variety of things.
Yeah.
And these 5, although I only take care of 5 cancers, the patient experience and the types of relationships that I have with patients, and even the impact of what I have, the impact that my work has on their life is very different for each of them. So it provides a lot of variety in what I do, all of which I love.
Mm-hmm. Yeah. Well, thank you, Stan. I know you love it. Your passion. It's whenever I talk to you, I hear it, and you can hear it now. I know that it's something that you love. And I used to hear George say that he's so glad that he gets paid to do what he loves to do, and I'm sure you do too. Um, so tell us, you pursued, becoming a medical doctor, but what inspired you to become a medical doctor, and more importantly, to work with cancer?
I often think about what it was that inspired me. And I have to be honest, it was something that I just started thinking about when I was very young. So
Mhm.
I think a part of it, if you've ever read the book by Michelle Obama, she talks about how when she was growing up,
Mhm.
when she would talk about wanting to be a pediatrician, she would get positive reinforcement for that. And I think to some degree, that's how it started for me. I think as time went on, I can remember being in the 8th grade and had to do a composition paper. And I chose to write about infertility. So I was always interested in obstetrics. The idea of delivering babies was something that was exciting to me.
Mhm.
And I think it was also a desire to help people in a way that as I grew older, I began to understand more and more what that meant. Now I know that that's exactly what it is. So I think we're gonna get a chance to talk about a little bit about my career and my journey inside of what I do. But
Mhm.
at one point, I was very focused on research and administrative leadership roles. So I really wasn't taking care of patients. And it became clear to me that that's not what I went into this for.
Yeah.
So I had to make a change a few years back, which took a lot of thought. But now that I'm back to taking care of patients, I know that that's what I went into this field for. I love the day to day of um, working with patients to solve problems and hear their anxiety and help them work through it. And even for the patients that I have to counsel through death and dying, it's a gift to me to be able to do that. It's
Yeah.
to be able to experience um, the honor, frankly, of a woman sharing with you some of the most intimate experiences of her life regarding her concerns about her pending death and how her family is going to deal with it. It's a very special thing that I think it takes a special person to want
Yeah.
to do that, and I think it takes a special person to do it well. So for me, it all comes down to wanting to help people. Um, and why cancer actually sort of goes back to a family experience of mine. So obviously, Cynthia, Pastor Russell's aware of this, but my grandmother died from breast cancer. And while she was in hospice, she lived in our house and my mom took care of her. And that was definitely, I think I was around 11 years old then. So it was a difficult experience for me to go through, but one that I was also able to link clearly to this is a part of what I want to do for my life. Like, and I think that's where the whole, for me, the attraction and ability to feel comfortable in that death and dying process comes from recognizing that death is a part of life, and I don't think often we celebrate it like that.
Yeah.
That it's a natural thing, and obviously there's all kinds of mixed emotion around it. But I love that I'm able to be in a part where I help people, women and their families deal with adjusting to that anxiety of it and dealing
Mhm.
with the fear of it and making it an experience that doesn't have to be completely frightening or isolating. Um,
Yes.
so, and that's what was the encouragement to go into cancer. I, like I said, I wanted to do obstetrics and gynecology. And then when I learned about this field where I could do obstetrics for 4 years, but then still do cancer and be a surgeon, it sort of wraps up everything that I love.
Yes.
And for me, my whole life, the idea of being a doctor was linked to taking care of people over a long period of time, which is what I get to do now. So
Mhm.
there are many women that I take care of who I'll work with for 10 to 12 years while they're dealing with their cancer coming back and recurrences. And to be able to play that role in a woman and her family's life is something that's, again, it's an honor for me. It's an honor and exciting.
Yeah, yeah. I can relate a little bit to when you talked about it, helping women to go through this experience, because being diagnosed with cancer, it doesn't matter what type of diagnosis it is. It's a very scary, scary situation. And I just remember when I was diagnosed, and even though you were in Minnesota and I was in Boston and you were not my doctor, I could call you anytime, and you took time to talk to me, and you took time to make sure that my doctor did what they could do, but it was just an extra added bonus to have you in my life to help me and to encourage me. And I wasn't as fearful, because any question was not a dumb question, was not a stupid question. It was a question that I can ask you, and you just right away just assured me, reassured me, and assured me in every way that I was going to be okay. And so that's why when I have this theme of cancer doesn't have to be a death sentence, it really doesn't. You just need to have information. You need to have, and no, everyone might not have a cousin, a brother who is a doctor, but as long as you have someone in your life, a doctor that you trust, you can ask those questions. I think it's just a matter of us. We've got to get to the hospital. We've got to know we have those symptoms, and we have to go. And I know that you're going to be talking a little bit about that later on. Now, you already talked a little bit about this, and you don't have to talk long, but what are you doing currently? And I know you did talk about that some.
Yeah, so I moved to Minnesota for my fellowship in 1998, and then I worked at the University of Minnesota, where I had an academic career. And academic medicine is it's an interesting part of medicine, where not only delivering patient care but also doing research and training future physicians was a big part of my life. So I worked there for 20 years. I was in charge of the division of gynecologic oncology at the University of Minnesota. Most of my research is centered around human papillomavirus and the treatment and diagnosis of cervical cancer, which is caused by human papillomavirus. That's where most of my thought leadership is, and where I play a lot of leadership roles today. So I will share that in April of this past year, I became the president of the American Society of Colposcopy and Clinical Pathology. So we're the society that determines what the schedule is for pap smears in the United States, and a lot of focus around how do we prevent women from getting cervical cancer.
Yes.
And so for 20 years, my life was writing papers, getting grants, doing research. And then I went on to become the chief medical officer at the University of Minnesota, where my clinical practice became a lot less. And I loved that job. I had it for 10 years. But after 10 years of that, I realized that I needed to go back to what brought me to medicine, and that was taking care of patients, and listening to patients, and being able to be there to solve problems for patients on an individual basis. A lot of what I did when I was in academic medicine was working to change healthcare for large populations of women. But I realize now that I got joy from that, but I get a lot more joy when I'm just sitting in front of my patient and helping to take care of her. So I still do a little bit of policy work around cervical cancer in the society that I'm leading right now. But for me, the joy comes from what I'm doing now day to day, which is I work at a medium-sized health system in the Twin Cities. I'm the medical director for gynecologic oncology there, which is a program at 2 different hospitals. And I have a team of about 12 physician assistants and nurses, and we'll be at 4 physicians once we finish recruiting. So that's my team. It's a little bit of a different job. I get to come home and do things like this, which is great. Whereas usually I was writing papers all night and doing grants or free time. Thank you for asking.
You're welcome. And congratulations again on your new position as the president. And I don't remember what you said in terms of the, congratulations on that. So we're gonna get ready to have Dr. Downs take some time. We're going to give him time to speak a little bit on cancer awareness, general medicine, advocacy, and anything else that he would like to share with us. Before I do, I just want to welcome everyone who has been coming online. You are so welcome to be here. And again, we're talking to Dr. Stan. I keep calling him Stan, but Dr. Levi Downs, and we're so excited to have him here. And Dr. Downs, there is one question that I have to put this in here, and you'll see why when I actually read this person's question. And but the person says, why does the host keep calling him Stan? Doesn't she know she is talking to Dr. Levi Downs Jr.? So you know who that is. That's our own brother, George Russell. And so he wasn't on in the beginning, but we established that we were brother, sister, and unfortunately, just like he slipped up and called me Cynthia, I'm slipping up and calling him Stan. We can't help it. That's the relationship that we have. But I will try my best to call him Dr. Downs, George, so that you're not offended by my conversation with him.
Cynthia, I'm certainly not offended by you calling me Stan.
I know you're not.
Cynthia told me I could take 30 minutes just to talk about and give you some information. I will tell you, though, I'm hopeful that I can answer your questions. And I think I've taken a little more time than we'd expected so far. So I have a series of things I'm going to talk about. And I'm going to shorten this a little bit so that it's a little bit under 20 minutes, 30 minutes, around 20 minutes or so. So then we have plenty of time for your questions, which is what my goal is, to hear what questions I can answer for the audience of encouragement along your journey. And I've just taken these as questions that I've heard from patients over the years and some things that I think make sense to talk about. And I'll just go ahead and get started. So
Dr. Downs, before you start, I just want to let everybody know, please put your questions in the chat. I will be monitoring them. And so after Dr. Downs is done, we will read those questions and he will definitely answer them. Go ahead, Dr. Downs.
Okay, so the first question that I'm going to address is the question, what is cancer? So a lot of people, when they get diagnosed with cancer, we all have in our minds these ideas of what it is. So I think a lot of us might think it's a death sentence. Some people think of a tumor growing somewhere where it's not supposed to be. That's certainly another way to think of it. But sometimes cancer isn't a tumor. And one of the cancers I take care of in the uterus, it's not so much a solid tumor that's growing, but it's just an abnormality of the lining of the uterus. But I can remember years ago, I went to this event called Cancer Sunday, which a collection of the Black churches in Minneapolis put together. And one of the ministers was speaking and likening cancer to any other, the source of many other problems, which is really just rebellion. And she described it as cancer is nothing more than a rebellious cell, which I loved. I think that's a perfect description in layman terms of what cancer is. So cancer in our body has a very specific set of what's supposed to happen to every cell that's made. And what cancer is one cell that somehow loses the ability to perform in the way that it's supposed to perform, and it begins to grow in an unregulated and rebellious manner. So that's what cancer is. As that cell begins to divide rapidly, it can grow into a tumor, or it can circulate in our blood as abnormal cells that spread around. And then that abnormal cells doesn't respect the boundaries that it's supposed to, and can begin growing into other tissue and destroying those other tissues to the point that it causes problems and symptoms for patients. A lot of times patients will ask, well, why did I get this cancer? And I actually kind of enjoy sharing this information with patients because it's something that people don't recognize. But in all of our bodies, all of our life, every day from the age of around 26 or 27 on, there are cells turning into cancer in our body. But the body has a very organized and effective method of screening every new cell to determine, is this cell correct or incorrect? Is this cell designed the way that it's supposed to be, or is it a rebellious cell? And when it finds those cells that are supposed to turn into cancer, which happens every day in our body, the body has a very good program, multiple different programs to police for those abnormal cells and cause them to die. So that's happening every day, all of our life. Cells are turning into cancer. As we age, that process of looking for and killing the abnormal cancerous cell begins to weaken. And as that weakens, cells are able to slip through the cracks. And there'll still be more opportunities in our body to get rid of it, but with a variety of different kinds of genetic problems, or just as somebody ages, that process begins to weaken and become less effective. And then a cell escapes that mechanism and turns into cancer. So for the most part, the question isn't so much why do we get cancer? That's a normal part of our process. We get cancer all the time. It's more that a cancer cell slipped through the cracks and was able to begin to grow. Sometimes that happens because there's a gene in our family that makes one of those policing systems ineffective, which would mean that we'd see many people in our family getting cancers, usually at relatively young ages. Sometimes it's because we may have grown up in an area where we were exposed to some chemical that's a carcinogen, so that there were more cells turning into cancer. And obviously, if you have more cells, that system of policing them is more likely to break down. I talked about human papillomavirus for one of the cancers that I take care of, cervical cancer. 100% of cervical cancer is caused by human papillomavirus, which is an infection that is transmitted sexually. And it's something that anyone who's having sex transmits. But some people, about 20% of people, aren't able to get rid of it. And that's another environmental effect, that after years and years and years of exposure to that virus, it changes the ability for the body to recognize the abnormal cancer cell and get rid of it. So whenever someone gets cancer, it's because something happened to break down that system that allows the body to screen for and get rid of cancer. So something else that I hear often from patients is, well, nobody else in my family has cancer. Why have I gotten this cancer? No one else in my family has had cancer before. Sometimes cancer happens because of a family trait or a family genetic predisposition. But the reality is that most cancers are not caused because of any relation or genetic process. Most cancers are sporadic, meaning the abnormality that led to that rebellious cell was a one-time impact on that one cell that didn't have a specific reason for it. It's just that our body wasn't able to catch it and get rid of it. So I say that to say that a lot of times patients are surprised that they got cancer, or they may say that they weren't doing the various recommended screenings because they didn't think they were at risk because it wasn't in their family. But that's a myth that's out there that really isn't true. The majority of people with cancer don't have a family history for cancer. Another question that I get, particularly from Black women that I take care of, is cancer different in the United States and the Black community versus the non-Black community? So, and that question is variable. It depends on what kind of cancer we're talking about. But in general, a very unfortunate thing is that in general, cancer is not necessarily more common in the African-American community, but in many, many different cancer types, like breast cancer, prostate cancer, cervical cancer, uterine cancer, two of the cancers that I take care of, colon cancer. The outcomes are a lot worse in African Americans than they are in non-African American patients. And that varies. Sometimes it's just the biology or the genetics of African Americans. That appears to be the case with uterine cancer, where women who are diagnosed with uterine cancer that are African American are more likely to be diagnosed with a more aggressive type of cancer, and they're frequently diagnosed at a later stage. Sometimes it's just because of cultural predisposition. So going back to uterine cancer, we know that there is a symptom that's associated with that cancer that tends to be somewhat frightening. So research has shown that postmenopausal bleeding frequently is respected differently in African American women than it is in non-African American women. Cervical cancer is one that we see differences, and it's not the difference that we might expect. So cervical cancer is a cancer that we have a screening program for in the United States. We know that Black women are twice as likely to die from cervical cancer than their white counterparts, even though Black women are more likely to have a pap smear. So in this setting, the reality is more of a burden on the health system. A lot of research has shown that when Black women present with an abnormal pap test, they're less likely to be recommended to do the appropriate follow-up to that pap smear. They're less likely to have the appropriate surgery or the appropriate treatment recommended to them. And although they're twice as likely in the inner city, or a third as likely in the inner city to get a pap smear, they're half as likely to have the right follow-up from an abnormal test result. We also see that in breast cancer, where in many studies we've seen that African-American women are more likely to get a mammogram performed. Unfortunately, when you look at outcome studies, we've learned that they're not as likely to have the appropriate follow-up or the appropriate management. All of which are reasons that I think it's important that we continue to pay attention to what are the causes of those disparities in outcomes that exist. Sometimes, just for that general answer though, sometimes it's because of biology, sometimes it's just because of cultural differences. African Americans, for a number of reasons, most of which are valid, obviously, with the history of healthcare in Black people in the United States. There's a lack of trust, which leads to sometimes different views on how abnormalities should be followed up or how a woman should deal with symptoms. So moving on from sort of the biology of what is cancer, we know that there are many different screening programs to help prevent cancer. So I just thought it would be responsible for me to talk about what those are. As far as prostate cancer and colon cancer in men, the recommendations are digital examination of the prostate at an annual basis once the man turns. Now the age range is pushed back to about 60. Sometimes you'll see clinics starting that at 55. With regards to colonoscopy, the age recommended for a colonoscopy now has dropped from 50 years down to 45 years. And then as long as your colonoscopies are normal, the recommendation for men and women is to have a colonoscopy performed every 10 years. There are new technologies for people who don't want to have the actual colonoscopy performed, which are just as effective and things that you should talk to your doctors about to find what's right for you. With regards to cervical cancer, which is the most successful cancer screening program in the United States, women are recommended to have pap tests performed every 3 to 5 years, depending on their age, now combined with an HPV test. For breast cancer, the recommendations vacillate between every year or every other year, depending on family history and the patient's age. There are a few other cancers that if you fall into a high-risk category, you're recommended to have screening for. There are new programs that are being developed for screening for lung cancer, particularly for people who smoke tobacco or have a long history of exposure to secondhand smoke. And I'll be happy to talk about other screening programs as well. Next, I wanted to talk a little bit about treatment for cancer. So as I described at the opening, I am a surgeon, so I do surgery for cancer. Unfortunately, most cancers are not amenable to having surgery. So we know that there are cancers that we call solid cancers, which are the ones that develop as tumors. And then there are blood-based cancers, which are lymphomas and leukemias. So those cancers almost never are associated with surgery. You can imagine if there's a cancer that's coming from our blood system, there's no real way to remove that cancer because it would be removing all of our blood. We do some mechanisms where we try to give patients new blood or blood that doesn't have those abnormal cancer cells in there, but it's not really a treatment for surgery. And then for the solid tumors, surgery tends to be limited to cancers that have not spread. Once cancers have spread widely across the body, then there ends up not being much of a role for surgery. Again, for the cancers that I take care of, it varies depending on the scenario around when a patient is diagnosed and how far her cancer has spread before she is seen for treatment. Another treatment modality is radiation therapy, which a lot of patients are recommended to have. Radiation therapy is treatment by delivering a very high dose of energy to cells that are dividing rapidly. So cancer cells, again, being that rebellious cell, they're growing out of control. So we can take advantage of that fact by giving them radiation, which will damage the DNA in the cells and cause the cells to die. In general, radiation is done when a cancer is somewhat isolated. So if a woman has a cancer in her breast or has cancer cells in her breast, then we'll deliver radiation directly to the breast. In patients that I take care of, when we see cancer growing at one place in the pelvis or in that region of the pelvis, we can deliver radiation therapy to the region of the pelvis. But you can imagine that if a patient has cancer that's growing in their brain, as well as in the lymph nodes in their chest, as well as in their abdomen, then the opportunity to use radiation at multiple spots is really just too damaging on the body, and it's not something that we do. So radiation tends to be limited to a region or a specific area where we want to treat the place where we think cancer cells are most likely. When we think about treating multiple places in the body, that's when we talk about chemotherapy. So chemotherapy is a broad group of treatments that is really only similar by the fact that it's chemicals or medicine that we're delivering to the blood. In the past 20 years, just the kinds of treatment that we include in that word chemotherapy have changed dramatically. So I do want to talk a little bit about those changes. I'll describe a little bit about sort of what chemotherapy was in the past. I talked about my grandmother who died with breast cancer. So just from the time when she died in the late 70s to the 90s, there were dramatic changes in what chemotherapy is. But it still was the same basic principle. Chemotherapy is a poison that we give to the body to kill cells that are dividing rapidly. The reason why chemotherapy tends to be a very hard treatment for patients is because although the cancer cells are dividing rapidly, there are other cells in our body that are dividing rapidly as well. So our bone marrow is regularly making new blood cells. So not only does chemotherapy harm cancer cells, it harms our bone marrow. The lining of our bowel and our gut is making cells regularly. So chemotherapy damages those cells, which leads to a side effect of nausea and vomiting for patients on chemotherapy. Some of the nerves are damaged by chemotherapy, so patients can develop neuropathy or tingling in their fingers or nerves, ulcers in the mouth, and that's the downside of chemotherapy. Although the nature of what chemotherapy is, traditional chemotherapy is, hasn't changed, what has changed since the 90s is that we have much better medications to deal with those side effects. So in the past, chemotherapy used to be a treatment that patients needed to pretty much be off work and stay at home for, whereas now with these medications to help patients deal with the side effects, a lot of the patients that I take care of are able to continue with their jobs, just taking maybe the week off or the week after their chemotherapy off. Since the 90s, there's been a rapid increase in the number of chemotherapeutic agents that we call biologicals. So I described that traditional chemotherapy kills any kind of cell that's dividing rapidly. When we think of these new agents that are generally categorized as biologicals, and if you know people who have had cancer treatment, probably one of the most common one of these biologicals is Herceptin, which is used very often in breast cancer. So Herceptin is a medication that treats a specific genetic mutation that happens in many different kinds of cancer. So the concept of these new biologicals is we'll test your cancer to see what mutations or defects or abnormalities your cancer has. And then we'll give you a medicine that will specifically target that abnormality. So you may have also heard of these as targeted therapies. In general, the ones that have been approved by the FDA tend to have effectiveness that matches or surpasses chemotherapy. But in general, they don't cause as many side effects or toxicities. And it's been a whole new group of medications that we can use to help patients live longer. Another one of these that's pretty common is a drug that's called Avastin or bevacizumab, which is a drug that's designed, we initially thought it was designed to kill the development of new blood cells, which is something that happens in cancer, but not in the rest of the normal adult body. So targeting that is a good way to potentially kill cancer without causing side effects to other parts of the body. And in fact, when we use that drug called Avastin, patients who respond to it can stay on it for a very, very long time. And many of them won't have as many side effects as they might if they were on more traditional chemotherapies. In the past 5 to 10 years, there's been a dramatic increase in the number of immunologic agents that are used for chemotherapy. So these drugs are also drugs that traditionally don't have a lot of side effects associated with them, and they're, for the most part, designed to stimulate your body's immune system to actually fight your specific cancer. So sometimes these are just general medications that will enhance any patient's immune system, so that if a patient has cancer, the immune system will recognize the cancer and then be stimulated to try and fight it. Some of the new immunologic therapies are actually taking immune cells from a healthy donor and then injecting them into a patient who has cancer. So for example, there's a lot of research for this in the setting of ovarian cancer, where we know that women with ovarian cancer have an altered immune cell called a killer cell. It's a T cell, natural killer cells that are designed to help fight cancer. If we look at the effectiveness of these cells in people with cancer and people without cancer, we see that there's a difference. So we've started taking donations from family members who have active and healthy natural killer cells and introducing them to the cancer patient. And there's a lot of promise that this is now looking like a very effective way to treat women with ovarian cancer. And it's taking information that we've been using for years in the treatment of patients with leukemia and lymphomas. Also, in regards to immune therapies, we've all become, since COVID, very aware of what vaccines do. So we're now developing cancer vaccines where we take a patient's cancer cells and we expose them to effective T cells, which are parts of our natural immune system, so that those T cells will develop a reaction to the cancer cell from a given patient's body. We let those T cells mature and develop, and then we inject them back into the patient. And it's like giving a vaccine against a patient's own cancer cells back to them. And that's something that's being used a lot now in pediatric cancers, and modalities, similar treatments like that, are going to be used more and more frequently in women or men with cancer. So those are the standards for treatment. And I'll go on to another question that I think is common. Often after patients are treated and their doctor will tell them that there's no evidence of cancer. And then we watch patients very closely because we know that in a lot of situations, there's a risk of the cancer coming back. So I will often be asked by my patients, Dr. Downs, you took out my uterus and my ovaries and everything was gone. So why is this cancer back now? There wasn't an ovary there for it to grow from. Why do we describe that the cancer has come back? So actually, that's a misnomer. When we say that patients have a recurrence of their cancer, almost never is it that a new cancer cell has grown or a new cancer is developing. Usually, particularly if it happens within 5 years of a patient's diagnosis, what we're really saying is that at the time that we first found this cancer, there were some cancer cells that either escaped the surgery or the treatment that we gave, and they were lying somewhere in the body dormant before they began to grow. Oftentimes, it'll be somewhat surprising too, because a woman will have a cancer in her ovaries, and then we'll take that ovary out, or cancer in the cervix, we'll take that cervix out, and then 3 years later, she has cancer growing in the lymph nodes in her chest or growing in her liver. The reality is that almost always those cancer cells at the time that we first diagnosed the patient had already spread to the liver and to the chest. It's just that we would have had no way of knowing that it was there. And then as time goes on, those cells begin to grow and we notice them and we'd say that it's a recurrence, but really it was just disease that was present but that we missed when it was first diagnosed. And then obviously, when we're dealing with recurrent cancer, it's a whole new set of symptoms and challenges to therapy. Most of the time, surgery is not recommended in the setting of recurrent cancer, but there are certainly many different cancers where that is appropriate. But most of the time, once a cancer comes back, the treatment is going to be chemotherapy or biological agents. And I'll say to my last question I'm going to go over before I start taking some questions. I think it's important to talk about what patients should do when they're diagnosed with cancer. I think one of the most important things for any patient who's diagnosed with cancer to do is to make sure that they find doctors that they are comfortable with. You need to put a lot of trust in the healthcare team that's taking care of you. And the importance of your having a relationship with your physicians that you trust them is very important. One of the most critical pieces of building that trust should be that you have a physician that listens to you. So I think that the very first few minutes of any patient's visit with their doctor for a new diagnosis, whether it be cancer or anything else, a question that you need to pay attention to is, did that doctor listen to me? At the beginning of a visit, no matter how much information your doctor has about you before you go into the office, this is my sort of quick measure for, is this going to be a productive or a fruitful relationship for me? If a doctor comes into the room just giving you information without taking the time to let you speak, I'm going to tell you that that's probably a quick read for a relationship that isn't actually that effective. So the most important thing that physicians do, and in fact, 300 years ago, 400 years ago, when this specialty developed, the career of being a physician, the most important thing that physicians did when they didn't have surgery or they didn't have tools and they didn't have medicines to give was that they listened to patients to hear what the problem was. And I will contest that to this day is the most important thing for physicians to do. And for you, it'll be a quick measure for, is this the kind of relationship that I want going forward? Because if you have cancer and you survive for some period of time, there are going to be many times where you need to have a better understanding of something. And if a physician couldn't listen to you when he first met you, then they're probably not going to be that effective at listening to you later on when you're confused, when there are questions that you have, or importantly, when you don't want to do what they're recommending that you do. And to me, that measure of how well they listen when you first meet them can be a great target for what that journey with that physician is going to be. I tell patients all the time, it's very important to get second opinions, particularly if you're not comfortable with that very first visit. But it's important that you have a doctor taking care of you that's going to make you feel like they want to partner with you. And again, as we all know, listening is how you demonstrate that partnership.
Mm-hmm. Dr. Downs, thank you so much. I mean, the information that you gave, and we really could have you stay here longer to speak, but it's just overwhelming, some of the information that you gave, and but it's also encouraging to know that there is hope. There's hope when it comes to cancer. There was hope when it comes to medical and anything that we go through medical, making sure that we're asking the right questions and that we get the right team of people that are on our side as we're going through some of these diagnoses that we might have to face, these challenges. There are lots of questions here. So we're going to start with the first question. One of the questions did ask about cervical cancer, but you did answer that. So I'm not going to repeat that question. But one question is there an age that a woman should stop getting tests?
Yes. So for cervical cancer screening, if a woman's not had an abnormality in the past, then once she reaches 65, if there's documentation that she's had 3 normal pap smears and HPV tests in the past 10 years, then at age 65, we recommend stopping pap smears. For colonoscopy and breast cancer screening, colonoscopy for women and men, breast cancer screening for women, the numbers vary, but in general, we're saying between the ages of 75 and 80, we can stop doing colonoscopy and stop doing mammograms. Other than that, there are different scenarios where patients may be exited from screening, but they're specifically things that you should talk to your doctor about to find out what their thoughts are on the timing.
Okay, thank you. The next question is, how do we as Black women get educated on what types of questions we should be asked for our follow-up care?
So you know what? Actually, that is a great question. I was at a conference just the other day where I learned about how Chat GPT is impacting healthcare. So if you go to Chat GPT and ask them, just tell them, I have a new diagnosis of breast cancer. I'm going in to see my doctor after my chemotherapy. What questions should I ask? I have been blown away by how true to life those questions that they recommend are. But you don't have to use ChatGPT. You can also just Google. I've finished my surgery for cervical cancer. What should I expect from my follow-up, and what should my questions to my doctor be? I think those are great ways to find out what questions to ask. But to specifically answer that question now, I think the questions need to be focused on what your concerns are. If your fears are, how long am I going to live? I think you should just tell your doctor, how long am I likely to live? If your concerns are, I have this specific side effect from chemotherapy, what should I expect the longevity of that to be? I also think it's important that patients ask their doctor the questions that sometimes we think we want to know, but we're afraid of knowing the answer to.
Mm-hmm.
And we might decide that because he didn't bring it up, it's not important. But sometimes that's just, he didn't bring it up because he forgot or because he wasn't sure if he wanted to hear. But if you're someone who wants to know what's the average length of time I'm going to live, I don't think it's something that you should shy away from. I think that that's helpful to ask that question, because then you can have a better sense of what to expect for yourself and how to prepare yourself. But you can also ask the question after that, so what can I do to make that as long as possible?
Yes, thank you. So the next question is, when I have a hysterectomy, do I still need to have a pap smear?
That's a great question too. So the guidelines right now say that if you've never had an abnormal pap test and the pathology from your cervix was normal, then you don't need to have any future pap smears. But if you've had abnormal pap smears in the past, then the chances are you're going to still need to have pap tests performed even after you have your hysterectomy.
Okay. Okay. The next question is, can you talk about what a family member or a loved one can do or say to support a woman who has been diagnosed with cancer?
Yes, that's also a very good question. You know, I find that it's just like I just said about being a doctor, a good doctor. I think it's just listening. I think often we're looking for, well, I'll speak to myself. I know that I'm often looking for the right thing to say. So um, I became a surgeon, and there's this joke in medicine that people become surgeons because their ego needs the gratification of solving the problem quickly. And sometimes for a patient who doesn't have an option for surgery, whose cancer has come back multiple times, who probably doesn't have a long time to live, it's an uncomfortable situation for the physician because you might not have anything to tell that patient or to say that's going to actually make the situation from your perspective better. Because my perspective is I want to help, I want to work with you to find the cure. And I find myself often like, I don't know what to say when I know there's not going to be a cure. And I've learned over the years that sometimes the best thing to do is just listen. And to the question that I maybe it's just the moment that I'm hearing that question right now. In general, I think a lot of times we're so focused on trying to find the right thing to say that we forget sometimes there's not a right thing to say. Sometimes it's just being there to listen and telling someone that you're going to be there to support them, asking people what they need without necessarily needing to feel like, here's the word I'm going to say to encourage you. I think sometimes the encouragement is just giving your ear and being present and sitting with someone and listening to them and
Yeah.
empathizing with them.
Hmm. Yeah. Thank you for that, Dr. Downs. I know that, as a cancer patient myself, and knowing people that are close to me who are cancer patients, one of the things that we find is that some people will just shy away and they won't say anything. They will just kind of cut us off. And that's the worst thing that you can do. If you are close to someone, you have a relationship with that person, don't cut them off. And I know that it's hard. Maybe you don't want to see this person suffer, or maybe you don't know what to say as this person just asked. But it's so important. And I'm going to emphasize what you said. If you just call the person and say, I'm here to support you with whatever you need, and I'm here to listen, that does so much more than just cutting the person off and
Yeah.
not saying anything, because it hurts the person who has the cancer, and they're wondering, do I have a plague, or what's going on with me?
I think sometimes it's also a great phrase to say to cancer patients is that I don't know what to say.
Hmm.
Just to let them know that you're thinking about them, you're present, but you don't know what words to say to encourage them. And that I have found can be very helpful too. I will say something this is probably for people who have maybe your more intimate loved ones, a spouse or a sibling or one of your parents. I have found a lot with regards to that listening piece. I think it's important to pay attention as well to where someone is on their journey. So I'll share with you a story that for me is very telling, and it's very common. Uh, when I take care of a patient who has ovarian cancer, who generally gets their diagnosis and lives anywhere for 3 to 7 years after that, by the time that patient reaches the end of her life, my experience has been that these women are almost always mentally and emotionally prepared for their death, and they are ready for their death. And sometimes the hardest thing for them is to see their family members trying to fight for them when they're ready to stop treatment or they're ready to move on with the next phase of their care. And that can be a very difficult struggle. But it's important to recognize that when we want to support somebody who's dying with cancer, sometimes we need to support them by putting our own fears, our own worries about the end of their life, and our own needs behind where they are with regards to this cancer. It's something
Hmm.
that I see all the time, and almost invariably when I mention to patients that my experience is that the anxiety is not around you're being afraid of dying. The anxiety is around how do you tell your family that you're ready for death, which
Mm.
can be very hard.
Wow, that's whoa. Okay. Another question is there a blood test specifically for cancerous cells in the ovaries?
So there's been a lot of research on ways to find cancer cells that are floating around in the body. And we know that most patients who have cancer do have cells floating around the body, but the tests have not been reliable enough to be able to accurately predict cancer. Obviously, when we find them, we know that it can help to predict that somebody has cancer. But there are now new tests that are being developed. I just learned recently of one, and I'm going to be learning a lot more about it in the future. It's a combination of looking for cancer cells plus looking at various different chemicals in the blood to help calculate what a patient's risk is of getting cancer. Right now, though, nothing like that is available for ovarian cancer.
Okay. Well, there's no other questions. And Dr. Downs, we are just so excited and so happy that you have joined us. We've learned a lot and we have a lot more to learn. And I am so grateful for everyone who got online with us this evening. And I really, really hope and pray that you were able to get something to speak to maybe where you are right now, or to be able to help yourself or help someone else. We are so grateful. We'd like for you in the chat, if you would just send up some emojis or just something to let us know. Dr. Downs know that you appreciate what he was able to offer and to give us. And I know he has so much more there that he could probably talk even another hour, but I'm looking at the time and I don't want to keep him as a busy schedule. And I'm going to tell a little bit about him. He texted me earlier to say, I'm getting ready to go into surgery. I hope I get there, but he came right home, came right in. And again, I am so appreciated. I'm so appreciative of him, of his busy schedule to be able to come and to share on this broadcast. So thank you again, Dr. Downs. Looks like I'm going to have you back because people are really, they're really putting things
Pastor
in.
Cynthia, I'd be happy to come back. Please do invite
Yes.
me. And for your audience that is watching this on the replay or on the video, let them know that they have questions. Please send them to you, and I'll be happy to give you some answers to send back to them. So
Okay.
this doesn't have to be a one-shot deal, and I'll be happy to come back whenever you invite me again.
Okay, that sounds great. Thank you so much. Thank you, thank you, thank you. And before we actually leave, all I'm going to do is just put up some announcements for everyone, and then we're going to go ahead and leave. So I just want to make sure everyone remembers that Encouragement Along the Way series is every second and fourth Monday of the month. And this month we're celebrating breast cancer awareness and celebration. So we're going to be doing that this month. Next time we get together, it's going to be on October 23rd. And we're going to be hearing some testimonies of women, and hopefully I might have a male who have been through cancer and we like to get their testimonies. We're going to give a little bit more of awareness and education. We'll have some resources. And then a part of our broadcast next time is that we're going to actually celebrate those who are, we call them miracles, who are not facing cancer right now. They've been through all their treatments, and we're going to celebrate them. And then we're also going to remember those who have had breast cancer and maybe are not with us anymore. So we're going to take time to do that. That is on the walls of Sister Still Standing. That's a broadcast or website that my sister and I have, Carla and I, and we have been collecting names of people to celebrate and people to remember. So if you know of people um, who might have lost their lives with breast cancer or any cancer, or you would like for us to celebrate, please send me their names because we're going to be reading those names and celebrating them on the 23rd. And then I just want to remind people that are in the Boston area. I talked about this last time. My brother George has released his next album. He released it on the 1st of October, and you can get it now. And he's going to be having a concert that's going to be at the Berkeley Performance Center on October the 27th. You can get your tickets now, and you don't want to miss the concert. I'm looking forward to going back to Boston myself to be a part of the concert. So you want to make sure that you're able to join in on this concert. You will definitely enjoy the evening. And then these are the ways that you can get in contact with me: CynthiaInspires.com, my website, information at cynthiainspires.com. That is my Gmail or my email address. And then, of course, if you ever want to just kind to help with the ministry, you're welcome to. My Cash App is $PC Russell. We would love to have you join in to help us. So as we close, again, I'm very thankful to have Dr. Downs with us, and I'm thankful for all of you guys. See you on the 23rd, and we're just so grateful. So thanks again, everyone, and thanks again to you, Dr. Downs.
Thank you for having me, Pastor Cynthia. Have a good
You're
night.
welcome. Good night.